Hello, my name is Christina Feng, and I will be speaking on the topic of updates in vascular anomalies. The International Society for the Study of Vascular Anomalies published classification schemes in 2014 and recently updated these in 2018. They are divided into two main categories, vascular tumors and vascular malformations. Vascular tumors are neoplasms or lesions typically characterized by the proliferation and hyperplasia of abnormal endothelium. Vascular malformations are considered congenital lesions made up of dysplastic vessels but are lined by normal endothelium with normal turnover. Simple malformations are classified typically by the principal type of vessels they are composed of and their Doppler findings, whether they are high or low flow lesions. This table shows a more in-depth classification of vascular anomalies, of which we will cover a few of the more common malformations and tumors in this talk, and also talk about malformations associated with other anomalies. And so we'll start with infantile hemangioma. Infantile hemangiomas are the most common tumor of childhood and can be found in up to 4% of children. Risk factors for the presence of hemangiomas include low birth weight, placental anomalies, prematurity, female gender, and Caucasian background. The most common location is the head and neck, followed by the trunk, and then extremities. Typically, the depth of the lesion determines its appearance, where the superficial hemangiomas will appear as bright macules and thus can often be seen earlier in life. The deeper lesions may appear as a blue mass in the soft tissue and may not be noticed until months later. The natural course of infantile hemangiomas is typically a faint spot seen at birth, followed by a growth phase in the first 1 to 3 months of life, followed then by an involution phase. And this phase can be fairly long and can last up to until the patient is 5 to 7 years old. Infantile hemangiomas are characterized by focal, which is the most common, and multifocal lesions, whereas multifocal lesions often are considered 5 or more cutaneous lesions. In the latter case, the physician should screen for liver hemangiomas as there's an association between the two. Depending on the location of the hemangioma, special considerations may be needed in terms of the prognosis of the lesion, how problematic they may be, and other workup that is needed. For example, segmental lesions on the face are at risk of ulceration or disfigurement and usually need to be treated early. And in this location, one may need to consider screening and workup for face syndrome, for example, which will be done with a brain MRI as well as other imaging studies. Hemangiomas in the beard distribution may be associated with airway hemangiomas and can lead to stridor or respiratory distress. Superficial hemangiomas in the genital or intertriginous regions are at risk of ulceration and complications due to their location. The treatment of infantile hemangioma is usually with a multidisciplinary team of dermatology, hematology, plastic surgery, general surgery, and interventional radiology. The high-risk category of hemangiomas should be identified early and referred to specialists early on. This category would include such as the following: those locations that have life-threatening complications, such as airway hemangiomas, large hepatic hemangiomas with high output heart failure or hypothyroidism, or ones with significant bleeding from ulceration. Lesions that can lead to functional impairment if they're not treated are also in this category, such as those in sensitive locations like around the eyes, nose, lip, or oral cavity lesions. Ulceration is the most common complication of hemangiomas, can happen in up to 5 to 21% of these lesions, and symptoms often include pain, bleeding, and infection. Ulceration is also more common during the proliferation phase. Finally, those with associated structural anomalies that will need multidisciplinary care may need earlier treatments and referrals. and those that can lead to disfigurement, depending on location, will also need to be addressed earlier, such as large hemangiomas or ones that are on the face that have rapid proliferation that can lead to significant scarring. The treatment of infantile hemangioma is usually observation, as most will involute spontaneously. Those that need treatment, however, can be treated first line with propranolol, which are given to patients typically older than 8 weeks with a target dose of 3 milligrams per kilogram per day divided BID. Side effects of this treatment include hypotension, bradycardia, hypoglycemia, and bronchial reactivity. Typically, those that start treatment stay on it for about 6 to 12 months, and we would ask families to hold the propranolol if the patient is at any point has decreased PO intake, either from fasting, illness, or vomiting, for example, and this is due to the hypoglycemia risk. Thin superficial lesions can be treated with topical beta blockers such as timolol, which is used for 6 to 9 months. Other treatments include pulsed dye laser or surgery for residual hemangiomas after involution or earlier if the medication doesn't work. Corticosteroids are less desirable due to its side effects, but can be second line if propranolol is ineffective or has contraindications. We will quickly talk about congenital hemangiomas, which differ from infantile hemangioma in that they are present at birth and fully grown and do not have a growth phase after birth. There are 3 subtypes of these, most common being a RICH, or a rapidly involuting congenital hemangioma, which should typically regress within 1 year. The other subtypes include non-involuting hemangioma as well as partially involuting hemangioma. The most common locations for these are also the head and neck, but followed by their extremities. One other category to note are the diffuse hepatic hemangiomas, which can lead quickly to massive hepatomegaly and compartment syndrome. These can also have complications of congestive heart failure due to arteriovenous shunts. They can be treated with medications typically to allow them to involute rapidly, but if they need emergent intervention, surgeons may need to perform a decompressive laparotomy or even a liver transplant to save the patient's life. These multifocal lesions are also associated with acquired hypothyroidism and often need thyroid replacement. Histologically, infantile hemangiomas are confirmed by the presence of GLUT1 positivity on immunostaining, where other lesions are all GLUT1 negative. The treatment of congenital hemangioma is typically observation, as most will resolve, and surgical excision is left in selective cases based on location and symptoms. Also of note, large lesions may lead to thrombocytopenia and transient coagulopathy, but these are usually self-limited and is not typically Kasabach-Merritt phenomenon. We will now move on to vascular malformations, which of note are present at birth, although they may not typically be clinically evident, and these grow proportionally with the child. They are GLUT1 negative, and they can grow due to infection, trauma, or hormonal changes. They are diagnosed typically with a good physical exam as well as clinical history, and imaging studies that can be used include ultrasound with Doppler or MRI or MRA. Capillary malformations are most common on the head and neck and can occur with other syndromes such as Sturge-Weber or Klippel-Trenaunay, and these are typically treated with pulsed dye laser early on. This helps to improve appearances in the long term. Venous malformations can be superficial or deep, and depending on the extent of the lesion, these are at risk of coagulopathy within the venous malformations. These are typically treated with sclerotherapy or in some cases sirolimus or surgical excision. Lymphatic malformations are typically simple, low-flow vascular malformations. They can be divided into three subtypes: macrocystic, microcystic, or mixed, which has both macro and microcystic disease. They can be located anywhere, but again, most commonly are in the head and neck region. The goal of treatment is mainly symptom control, as these grow and progress over time. The treatment of lymphatic malformations are typically via, again, a multidisciplinary team approach. And options include observation if they're asymptomatic, or usually first-line treatment is sclerotherapy, with the agents listed here. Surgical resection is typically left for those that are not amenable to sclerotherapy or in a sensitive location. And at times, systemic therapy may be used, and these are typically better suited for microcystic disease. Systemic therapy will often involve first line is sirolimus, and the role of sirolimus in the treatment of vascular anomalies was published in a 2016 study looking at 61 patients with a variety of vascular anomalies diagnoses, but most commonly microcystic lymphatic malformations, who have failed other treatment options or had complications. They treated patients with 12 courses of sirolimus, and they were looking at responsiveness of the disease to sirolimus at the end of course 6. The results showed that a majority of patients, so 83% of their patients, had at least a partial response by course 6 and 85% by course 12. These patients also had significant improvement in quality of life. Overall, sirolimus was well tolerated, but the authors cautioned on monitoring for adverse events long-term, given at times the need for ongoing treatment. We'll now move on to talking about a few overgrowth syndromes, which are termed PROS. The somatic activating mutations in the PIK3CA gene has been shown to be present in multiple syndromes of overgrowth, and these can be with or without vascular anomalies associated with it. Downstream effectors of this gene include the mTOR pathway, and there's a wide spectrum of overgrowth seen, sometimes in a single location, other times with diffuse multisystem involvement. One of these, more commonly, is Klippel-Trenaunay syndrome, which is diagnosed by the presence of capillary malformations, venous malformations, and limb overgrowth with or without a lymphatic malformation associated with it. They commonly involve the lower extremity, and the capillary malformations are usually sharply circumscribed and at the lateral part of the affected limb, and they may at times also have an underlying venous malformation. Complications in Klippel-Trenaunay include infection, cellulitis, or an abscess, and they can also have bleeding into the lymphatic malformations, leading to swelling and pain. Those that have a significant portion associated with venous malformations also have a more serious complication associated with it, which include thromboembolic complications such as DVT or at times pulmonary embolism. Another more common one of the PROS spectrum is CLOVES, which stands for congenital lipomatous overgrowth, vascular malformations, epidermal nevi, scoliosis, skeletal and spinal syndrome. These patients have progressive asymmetric overgrowth combined with vascular anomalies and musculoskeletal abnormalities, as well as the cutaneous lesions. Some of the examples are shown here. Lipomatous overgrowth often involves the trunk, and vascular malformations usually have a combined lymphatic, venous, and capillary component that are all slow flow. In order to diagnose patients with PROS, a tissue diagnosis is often needed, as these mutations are typically undetectable in the blood. Thus, they need a biopsy at the site of overgrowth to be sent for gene sequencing. Additionally, these have variable mutation burdens. And so, even with the best sequencing, sometimes they can miss up to 65% of these mutations. And so, negative results from sequencing does not necessarily exclude PROS if the patient has typical features of it or a physician is highly suspicious of it. Sirolimus has been an effective treatment for patients with PROS, and in Klippel-Trenaunay syndrome has shown to stabilize the disease. It can also reduce tissue growth as it targets typically the growing tissue. Other treatments medications include PIK3CA direct inhibitors, which has been approved for certain cancers, but are more recently trialed in patients with PROS and shown to have good effect. In patients with CLOVES, they have shown reductions in the capillary malformations and the epidermal nevi, and they have also found to lead to discontinuation of chronic GI bleeding in patients that have those complications, and they're overall well tolerated without significant organ toxicity. These are a few references for recent advances and updates on the topic of vascular malformations and vascular anomalies. Thank you all for your time.